Good morning and welcome to today's seminar, The Future of Health in Latin America, Getting to Work on the Workforce, organized by the Latin American program at the Wilson Center and co-sponsored generously by United Health. I'm Benjamin Gadan. I'm Deputy Director of the Latin American program here at the Wilson Center. I will be the moderator for today's important discussion. As the highly contagious Delta COVID-19 variant spreads in Latin America, the region's hospitals are once again enduring a surge in patients. The latest pandemic wave falls on the shoulders of healthcare professionals who have already borne an unimaginable burden. In the early days of the pandemic, lockdown residents of Buenos Aires and other cities applauded healthcare workers from their balconies every afternoon. But as this public health crisis has continued, we've often focused more on the scarcity of PPE, personal protective equipment, intensive care unit beds, ventilators, oxygen, and vaccines, than on the state of healthcare workers who care for those suffering from this debilitating virus. Globally, tens of thousands of healthcare workers have died of COVID-19. In May, the Pan American Health Organization, PAHO, estimated that 1.8 million healthcare workers in Latin America alone had been infected with COVID-19 and 9,000 had died, mainly female nurses. Healthcare workers in countries including Argentina, Brazil, Ecuador, Mexico, Peru, and Venezuela have protested the lack of medical supplies and sometimes dangerous working conditions. Many have left the profession entirely during this pandemic. These profound challenges are worsening the region's chronic undersupply of healthcare professionals, which is the topic for today's Wilson Center conversation. Even before this pandemic, Latin America had on average only 2 doctors and 3 nurses for every 1,000 people in the region, according to a recent report by the Organization for Economic Cooperation and Development, the OECD. By comparison, in OECD countries, there's an average of 3.5 doctors and 9 nurses per 1,000 people. In Latin America, there are many cases such as Haiti, Honduras, and Guatemala, where that gap is even more extreme. There are many causes for this personnel shortage, including generally inadequate spending on healthcare throughout Latin America. The region spends on average only about 3.8% of GDP on health, which is compared to 6.6% in the OECD region. The region also struggles to recruit, train, and retain healthcare professionals, in part a consequence of brain drain to the United States, Spain, and other systems with higher pay for medical professionals. The results are clear. Experts today estimate that Latin America needs as many as 100,000 more doctors and nurses just to staff the region's intensive care units. To learn more, I'm joined today by a spectacular panel of healthcare experts, including Ana Maria Malik, coordinator of FGV Saúde at the Getulio Vargas Foundation. She joins us this morning from Sao Paulo. Liliana Hadwe, Vice Dean of Careers in Health at Chile's Universidad de Desarrollo, who's in Santiago today, and Roberto Tapia Conier, Director General of the Carlos Slim Foundation in Mexico, who joins us from Mexico City. I also want to hear from you, your views on these challenges, your experiences in Latin America's health system, and your questions for our panelists. Please reach out at any point during this conversation. You can send questions to us on Twitter through a direct message or by tagging at LATAMPROG, at LATAMPROG, or you can send an email to LAP, LAP, at wilsoncenter.org. Once again, please feel free to participate in the conversation. We'll be eager to hear your views, concerns, and experiences regarding this pressing public health issue. Let me begin by welcoming you and thanking you for being here, and also you, Ana Maria, Liliana, and Roberto, for joining us on this conversation. I'm going to start, Liliana, with you. And I want to talk about the times in Latin America before this pandemic began, because as I referenced in my introductory remarks, the region has struggled to have enough healthcare personnel throughout the public and private healthcare systems for a very long time, again, predating the challenges that I've just outlined that Ana Maria will talk to us about in a few minutes. So Liliana, please just describe the scale of this problem, its historical origins, and how it has impacted care in Latin America, starting from years before COVID-19 became a challenge in the region.
Thank you very much, Benjamin. The medical professionals, particularly medical doctors in Latin America, they graduate from the universities, and I can talk mainly about Chile. We are one of the countries we have 2 medical doctors for every thousand people. And the main complaint before the pandemic was the lack of specialists, not for general doctors, but for specialists, because we do have a public health system that has good coverage of all the population with general doctors, but specialists are the problem. About 2014, the Ministry of Health developed a particular program incrementing the formation of medical specialists from around 300 per year that were the places at that time to 1,000 or more than 1,000 scholarships per year. The impact of this program is being seen now, that it's not enough yet. And but in that period also, the universities increase a lot the number of the number of students coming into the universities for the different careers of health, particularly nursing, physical therapist, and dentistry. So in this case, we've been increasing the number of professionals, but anyway, we have a long waiting list. On the other hand, there have been many medical doctors coming to Chile from other countries, mainly Ecuador, Colombia, and Venezuela. Actually, today, 20% of our medical doctors, 20%, are coming from particularly these three countries. Many of them are specialists, actually, but all the laws or the regulation for them to practice medicine or being recognized as a specialist in Chile, it's been very difficult, very long. There are some countries that have immediate recognition of their formation, but for others, this is a problem. It's a problem for everybody, because you can have a neurologist or a pediatrician working as a general doctor in primary health care. In Chile, we don't have a law to recognize specialists. Okay, you can do whatever kind of specialist you want, but there are commissions created by the universities and with the help of the state to recognize specialists, and this system has been more efficient to put these people, to enable these people to work on our health system. So I think that our situation is a little bit different from many other countries. Well, as countries have been mentioned, they lost their health professionals, and when the pandemic came, then and every one of these problems became worse. So the situation is worsening day by day with these problems.
Liliana, since you brought up the case of Chile, maybe before we move on, let's talk for a minute about how much the public has been focused on these staffing shortages, including, as you've mentioned, for medical specialists. You know, Chile obviously has gone through a period over the last now 2 years of public frustration with a lot of public services, and healthcare has been among them. You now have a presidential election underway. You also have a constitutional reform process. Can you talk just for a minute about how much healthcare has been part of the public discussion and now these big policy debates as Chile considers ways to remake Chilean society?
Well, that's a big issue in the debate, because the constitution that today it is established that healthcare is a right, but in the conventional the convention for the laws, it's a subject to establish law as a right, and there are problems establishing the health system. We do have a big public system and smallest private system, but resources are mainly situated in the private system. And to consider universal insurance and universal access to health care, it's a big issue. We do have today almost universal access, but the problem as there is shortage of professionals, we have huge waiting list. We also have this system instituted by Ricardo Lagos in the 2000 years, a program called HES, which is established guarantees for around 82 health problems with particular with protocols and waiting times established by this program. But with the shortage of services, this program is also creating a waiting list. We also had a huge earthquake 10 years ago that destroyed almost half of the hospitals. So there is a big issue rebuilding all this infrastructure, and that's why the convention is really worried about ensuring the right to healthcare access for everybody in every condition, in every moment.
Thank you, Liliana. Ana Maria, I want to talk now about this phenomenon, but in more recent period of extraordinary challenges. Liliana, I think, has nicely laid out, particularly in Chile, but these are problems certainly not unique to Chile, of an undersupply of medical professionals in Latin America. This has come to light during the pandemic, and I think been worsened by the extraordinary burdens on the region's doctors, nurses, medical professions of every stripe. We can talk about Brazil, which has obviously had one of the worst experiences with COVID-19 in the world, but also regionally, if we could, what has happened? What have we learned about the healthcare workforce over the last year and a half, and how has it changed as a result of the burdens of this pandemic?
Okay. So thank you very much, Benjamin, for the question to start with. And thank you very much, Liliana, for telling me at least about Chile. So Brazil has health for all, a very Bavarian model, but Brazil has is a very heterogeneous country. So we usually say we have several Brazils. So we have differences in terms of human development indexes and so on, and income in the different states. And even if we're talking about our universal coverage, we have 200 million inhabitants, but this is a lot of money, so we have sort of 9% of our GDP to health, devoted to health, but even with such a huge population, we can say that, unfortunately, sort of 51% of the coverage of the GDP, of the money, of the budget goes to the private sector. Only 49% goes to the public sector. And when we talk public sector, we are talking about surveillance, we are talking about technology development, vaccines, and so on and so forth. So medical care is just a part of it. While in the private sector, it's basically their business, what they do. So, and if you talk about the coverage for these, let's say voluntary health insurances, they are also very differently through Brazil. They spread through Brazil. So what we see is that, again, when the pandemic started, we realized, well, we health professionals, we health management professionals did already know that, but we saw the humongous differences between public and private coverages. So in terms of ICU beds or the availability of other kinds of resources such as individual protection equipment and so on. So that was very different. And then our several Brazils have an issue that in the big centers, but this is universal, in the big centers, in the big capitals, in the sunnier regions, we have more health professionals. If we go to poorer areas, we don't have professionals at all, or almost not. So we had some policy, some federal policies regarding that kind of coverage, but this was, it even changed when we had the new president-elect. As soon as his election came, lots of things changed in this policy. And we saw that what we had as a coverage of primary health care also diminished a lot. On the contrary of what Liliana just said, we don't have enough generalists. We have a culture of specialists. And so when people started to talk about staffing hospitals and ICU beds with physicians, many people realized that a physician does not know how to do everything. So dermatologists don't really intubate very often. And so people realize that physicians and physicians are different between them. The same thing regarded the nursing professions. So in Brazil, unfortunately, again, we don't have a big emphasis in technical professions. So in Brazil, people value more people with university degrees, and this also has a consequence in terms of nursing staff. It was a great thing to see that the nursing professional started being more recognized during the pandemics, because people realized that you need care, you need 24/7 care. And so this was something that enabled people to see what happens in terms of how important nurses are. And then there's the third part of the equation that deals with the rehab. So rehabilitation, like physical therapists and so on, are not usually so considered. So all of a sudden in ICUs, people realize that you cannot have a functioning ICU without physical therapists, for instance, or technicians in rehab. So the pandemic also arised some looks at that. Even if we consider that we are in the chronic disease moment, so the 21st century shows that, but it has not been recognized so far. So I think it was, if you look at the glass half full, it was an important moment for, awareness. If you look at the glass half empty, you say, we are not very well there. But we have seen also some alliances between public and private sectors, not only health related, in terms of being able to pay for ICU shifts, because many of the physicians didn't feel comfortable or didn't feel tempted to go back for night shifts and so on in very demanding ICUs. So in a short moment, for a short period, there was a small increase in payment for them. So I think this is what I think is the most important for the time being. And then
thank you, Ana Maria. I appreciate your effort to bring a note of optimism. I think obviously these are dark times, but you're right. I think increasing awareness, I think, is very meaningful because it can translate, hopefully, to public responses. And I think that's what I wanted to turn now to you, Roberto, to talk about, which is, we've heard from Liliana that this has been a challenge for a very long time in making sure there's adequate healthcare personnel. We've heard from Ana Maria that the unfairness of the quality of care being different in public and private systems, but also the inequalities in rural areas and urban areas have also come to light, and that there's been a much bigger, at least in Brazil, recognition of the challenges in staffing medical facilities. My question, Roberto, is now that we've had a long period of being aware of this issue that Liliana's explained, we've seen these issues really come to light with really grave impacts on the quality of healthcare. What has been this short-term response that you've seen as governments have had to fill these shifts in medical facilities? And afterward, we will talk in our next round of questions about longer-term ways to address this in education and training and recruitment. But Roberto, if you would, I wanted to hear your perspective regionally and from Mexico on what have been short-term responses to make sure that patients are cared for during this very extraordinary public health challenge.
Thank you, Benjamin, and it's really a pleasure to be part of this panel. There's no question that we have to recognize the courage and the willingness of all the health personnel to step in and to really have a proactive and really have a humanistic approach. And even in the first days or first weeks of the pandemic, I would say that under very risky circumstances, with time, the PPE equipment came in and they were more protected. But I would say that in the first months, I think it was a real challenge. And the other aspect was that the response was very heterogeneous. As Ana Maria mentioned, I think there was some reactions, and due to the distribution of health personnel, which is quite heterogeneous, and it happens the same in Mexico, it has been described in Brazil or in Chile. It tends to be in huge urban areas or metropolitan areas where you have other opportunities and there's less incentives for the health personnel to be out in the rural or suburban areas. But as mentioned, I think the issue was to really cover the shifts and the capacity for ICU personnel, and even for the triage, for those that have to make the decisions, what's the level of severity that the patient has. And that's where there was a lot of innovation, I would say. I think even though it was a crisis, within that crisis, there was the capacity to innovate. And it was like really habilitating, I would say, in a way that it was even risky to put general practitioners or public health nurses into the hospital settings or ICUs, and to really use, I would say, really innovative strategies to train those people and to try to have a response. Obviously, there were consequences because the quality of care wasn't at the level that I would say today it is, due to the experience after more than 1 year of clinical experience. So that's one point. And I think that we have emphasized a lot the challenge about, let's say, tertiary, secondary hospitals. But I think there was also a challenge at the primary healthcare settings where many of the community approached those primary healthcare settings asking to really be diagnosed. And that's the other challenge, was the capacity for testing and to do those elements, to really have a true diagnosis and to really have the criteria to really what to do. And I think the other aspect that I would say it made it a very difficult situation is that there was no skills and there were no elements, clinical criteria, how to handle cases, because there was no therapeutics, there was nothing. We in January knew about the genome of the virus, but nobody knew really the physiopathology of how it was causing all this. And then through the different weeks that we learned, we started to see, and at present, there's only very relative, let's say, clinical protocols. And it was very useful to have WHO and NIH clinical protocols that were trying to assimilate the knowledge that was in place, and that really was and I would end like saying that was a challenge. How do you really spread it out? How do you really spread out the information for that? And there was at the same time a lot of misinformation about products There was a lot of second-hand products that intended to be useful during the treatment. So it was part of this whole crisis. And I think that the response was very, I would say, more encouraging and really, I would say, enthusiastic. And at some point, really, it went over their capacities for a number of health personnel. As you mentioned in your introduction, the number of fatalities, the number of infections, it was only an expression of the lack of preparedness that we had. And I would say that COVID came once more to say that we need to really build up a workforce that is prepared in different circumstances. So I would end with that.
I'm glad you did, Roberto. It's interesting. I mean, I want to follow up with you just for a moment. You know, a lot of what you described seemed to be innovative, nimble responses to a novel virus and a crush of patients that maybe would be difficult for any public health system or private system to manage. And so a very sui generis situation and you know, a response that had to be quite nimble and risk-taking in some ways. And I think, you know, you have to then be sympathetic and say, okay, this was a system that was overwhelmed in the systems throughout the region. On the other hand, you ended on the question of resilience and preparedness. And I want to just draw that out, if you would, for a moment, which is, what would the response have been had the system demonstrated a greater resilience and a greater preparedness? What could we have realistically expected, even recognizing that the unprecedented scale of this pandemic would have strained even the most prepared, best resourced and trained public health system? Could we still have had better results in Mexico and elsewhere if the systems had had higher levels of staffing and training?
Yes, I think that's a very good question and with a very difficult answer. But the point is that regardless of what level of preparedness, we need to be conscious that there's a need for a policy, for more strategic investment. I think we're always calling about health reforms, financial reforms, but do we really need, I think that we really need to really focus on what are the elements that you need to have within a system. Let's not say about a pandemic, just an emergency, like Chile and in Mexico, earthquakes. What's the response that we have around that? If there's also another public health emergency, nationally or even as a pandemic, you need to be prepared in a way that you have a strategic response. And I think that COVID came to bring that setting up. There's already a lot of institutions, many universities and other health organizations really looking at what to prepare as really calling it a preparedness process for the next pandemic. And I think that's very good because we have always been like a bit, let's say, limited in the perspective. And we need to see it from a broader way. And I think that the aspects of digital health is also an alternative that we need to bring into on the table, because that was a very good way to really reach out. And as we saw later during the pandemic, the use of telehealth and other elements really helped to let's say, to reduce the problems of health coverage. So I think we need to include those elements in a different perspective from the primary care, healthcare, to the other process. And Ana Maria mentioned the issue about technicians. We need to really reinforce technicians. Technicians, for instance, for ventilators, technicians for the use of other elements within an ICU unit, technicians for rehabilitation. I think that we need to really have an open mind and to be very conscious that what's the worst scenario, what are the elements that can come in place, and also looking at the financial sustainability of that.
Thank you, Roberto. And we will, when we get back to Ana Maria, I want to talk more about technology. as potential solutions here, and some of the more optimistic elements of the recent experience, telehealth being one of them, to address these disparities in access to healthcare in rural areas, which Ana Maria, you've raised earlier. But before I do that, Ana Maria, if you'll allow me, yeah, please go ahead. Go ahead.
A little pessimistic before.
Sure.
I'm so sorry about that, but nevertheless, COVID was not the first pandemic of this century, and it's definitely not going to be the last one. So I think that what we also have to stress is what today we call resilience, but also the organizational learning for health systems and so on. So what are things that have to be applied universally? So what kind of ability to negotiate, ability to talk, ability to raise resources, fundings, and so on. We saw that this is very important. For instance, in Sao Paulo, there's a university hospital that is a reference point for lots of crises, health crises, diseases, and so on. So let's say that 10 or 15 years ago, they had some of these emergencies, and they developed a crisis committee. And so as soon as they saw what was coming, they called the crisis committee that was not with the same people that were 15 years ago, but nevertheless, they sort of had already, let me be old besides pessimistic, a compass to orient what they were going to do. I'm not going to say ways. So, and so it helped. It definitely helped because people did already know what protocols to follow. I mean, to step out from decision making, the regular people, and leaving it for the committee, so on and so forth. So I'm sorry, I just wanted to say that. I mean, we're not done with COVID.
I appreciate that, Ana Maria. And as I said, when we get back to you, I do want to talk a bit more about technology and how telemedicine and some other technologies have been able to take advantage of digitization in Latin America to maybe address some of these gaps. Liliana, though, I wanted to return to you on this question of resources and the financial sustainability part of this. In Chile, the public demands are clear for what kinds of government services are being requested now, and a real focus on inequalities throughout Chilean society. But the question of cost looms large, and Chile is one of the wealthier areas in the region. So elsewhere, to try to realize the vision that Ana Maria and Roberta have laid out is not inexpensive, particularly to have the kind of built-in resiliencies for extraordinary crises means that you're paying a great deal in better recruitment and training and retention for your healthcare workforce, not to mention technologies. I just want to know how much of a limit on the kinds of responses that are needed are the strained budgets in Latin America. Obviously, public health impacts have not been the only impacts of the pandemic. The economic impacts have been extraordinary throughout the region. The economies were growing slowly before the pandemic. The protests in Chile, as we'll remember, were in 2019, before the pandemic, already expressing public frustration with the level of government services, among other issues. So my question, Liliana, is on the financial sustainability and the affordability of the kinds of reforms that Roberto and Ana Maria have said are urgently needed.
Hard question. I have to say that there are some things that were completely different in Chile than in many other countries. Actually, the government put many resources to manage the crisis. The Ministry of Health at that time was able to, to buy ventilators. The number of ICU beds were tripled. And every resource was mobilized to manage the crisis. Actually, I have to say that our specialists, our dermatologists, were taking care of patients and everyone. Even there were conditions, regulation made for hiring medical students from the latest years to help at the hospitals, and they were very relevant. The smaller students the students not in their final year were hired as technicians. So they made a lot of difference in the hospitals. The primary health care and caring of non-COVID problems, as is happening in many other places, is now going to be the problem. And actually, there is an issue. All the candidates, presidential candidates, have been offering programs to address the needs of COVID survivors, because they need rehabilitation, they need a lot of support. It's a lot of damage for the body to have COVID. In terms of resources to manage the pandemic, the government put everything they had. This is going to be a huge problem for the next years because of these many reforms that have to be made. Well, next government's problem is going to be we'll have to afford or to see what's going to happen. But I'm sorry about my rusty English.
No. Your English is spectacular. So I guess my question, Liliana, is, in a situation with a seemingly limitless budget for this public health crisis in Chile, were those resources able to mobilize personnel? I mean, so you've talked about creative short-term solutions, mobilizing senior medical students to be able to be helpful. Roberto talked earlier about similar juggling of personnel in hospitals, bringing people into intensive care units who weren't originally trained for that challenge. But what about in the medium term after the pandemic? I mean, that kind of spending could triple the number of ICU beds, as you mentioned, in Chile, and purchase ventilators, but you can't purchase overnight more doctors and nurses and medical technicians. So is it a question of spending alone? And if so, can Chile, produce an adequate number of medical personnel simply through greater spending, or are there more challenging policy solutions that are needed?
No, things change forever. Nothing is going to be the same, not the health system, even not the universities. All of the universities actually, I would say that generosity has been the value that helped us during the pandemic. Generosity from the public health sector, from the private sector, from everyone. So we've been working a lot, changing curriculums. Simulation and Zoom are our best friends now. So we can train students more rapidly. And on the other hand, even before the pandemic, there has been a lot of reforms in the educational system so that students can come to the university with gratuity. Chile has a lot of universities, very good ones, but it is very expensive to go to the university. And before the pandemic, this was being implemented, gratuity in many universities, public and private. So access to study health careers is much more accessible now, and we are going to see the impact probably in the middle term, because the increase of this number of students coming into the university, it started like 3, 4, 5 years ago. So we expect to have a much more personnel for the health system, public and private. Besides, the ministry is working a lot on implementing technology. The pandemic accelerated these changes. Previous ministries have been working in using much more technology, but did not succeeded. The system is always so slow. Changing people is so difficult. But the pandemic accelerated all of these systems, and we, the universities, collaborated a lot. With courses, with seminars, with formation of people, free of charge for anyone coming from the university, from scientific societies. So we think that things are going to be very, very different, and curricula in all health careers is being updated to include this technology, to include the use of technology, the knowledge of working with much more technology. And as I said, the government is is elaborating plans to put this technology at service at all institutions, primary healthcare and hospitals. That will help a lot to manage things, because we expect terrible problems now with non-COVID health problems that have been neglected or have been postergated because of the pandemic.
Ana Maria, talk to me about in Brazil and elsewhere that you're following the technology piece of this. So Liliana has talked a bit about technology and focused a lot on recruitment to medical schools at universities, ways that even predated the pandemic to broaden the number of students who are coming in to be trained in medical professions. I want to focus on the technology piece and what we've learned about the speed with which we can digitize healthcare in Latin America, including in Brazil, ways that we can reach hard to reach rural communities with inadequate numbers of medical professionals. Is there something positive that we've experienced with medical technology over the last year plus that can maybe help us in the long term deal with these workforce challenges?
Yes, there was something positive. I thank you for the question, but there's a pledge that I've been doing for the past 10 years or so. In Brazil, differently from what happens in the world, the councils, the professional councils, are not happy with physicians working in telehealth or so. So believe it or not, in the beginning of 2019, they launched a possible permission to work with this, and well, they decided to change their minds. So in the 1 year after, in the beginning of 2020, they said, okay, physicians can work with telehealth while there is the pandemic. So God only knows what it means, because we still don't know until when we are going to have the pandemics and so on and so forth. At the same time, we have, again, in the several Brazils that we have, some places where coverage with Wi-Fi or whatever does not really exist. And of course, life is not as simple as many people would like. So round tables or panels like this one, it's not a simple matter of turning on a digital platform and here we are. There is some more technology required and so on and so forth. So in Brazil, we've had the opening of several medical schools and of several nursing schools, again, very heterogeneous among them. So in some of them, the tele stuff is already being taught since day zero in terms of ability. For some, tele stuff is being used just as a support technology while classes are not in place, and definitely. So the heterogeneity is very, very strong. We don't, for a big part of the population, it has been helpful. The population has been adapting more easily than some professionals, I have to say, especially if they have the means for that, remembering once more the heterogeneity of the country. There was a survey done by the São Paulo Medical Association that showed that, for instance, for the physicians that answered the survey, which was not a huge number, so we had like 1,000 or 1,500 answers. It was a heterogeneity like crazy. So some of them said that they did it, but they were not paid for that. Others said that they did it, but they were paid exactly as it was in face-to-face relations. Others said that they were paid more than on face-to-face encounters. Then they said that they've never had any kind of training. Others said that the population supported the online. Others said that the population hated it. So 1 year and a half into it, I don't think or as far as we can see, besides people who advocate for that, there has not been a serious measure. There are serious academic researchers who are working towards that. I'm talking about the real world. The real world is not ready for that. So when we say that internet is the new electricity, so you won't be able to live without it, this is true, but not that much. So we still have a long way to move in Brazil. We have to develop a culture. We have to lose fear. We have to overstep distrust, and we have to think that the most important issue regarding telehealth or telemedicine is not how it's going to be paid for. And this is the only technology I'm going to talk about right now.
Thank you, Ana Maria. I want to remind everyone to please continue sending in your ideas and reactions and questions so you can participate in this conversation this morning at the Wilson Center. You can reach out on Twitter through a direct message or by tagging us. We are at LATAMPROG. That's at LATAMPROG. Or you can simply send an email to lap@wilsoncenter.org. lap@wilsoncenter.org. Please do continue sending your reactions and thoughts and direct questions for our experts. I want to turn to you, Roberto, again, and I want to talk about this question of brain drain and the movement of medical professionals throughout Latin America and from Latin America to other markets. Liliana had talked about some countries that could benefit from this movement and how Chile had been attracting large numbers of medical professionals from within Latin America, so Spanish-speaking medical professionals who were looking for higher wages. And I'm interested in your sense of countries that do benefit from this movement of medical professionals and also how they can make sure they take advantage of it. And Liliana referenced the idea of needing to certify these foreign trained professionals, degree validation efforts, facilitating their hiring and their permission to work. But also the flip side of this, countries like Peru, Jamaica, and others who lose a lot of the medical professionals that they train at the public expense and then suffer from shortages. So both sides of this issue I ask you about, Roberto, the countries that are benefiting from it and how they can take advantage of these opportunities, and also the countries that are suffering from what's often known as brain drain and how they may improve retention of the medical professionals that at great expense are trained locally.
Thank you, Benjamin. If you allow me, just a short comment on what you mentioned with the technology. I am a true believer that the health systems need to go through digital health transformation in a very profound and serious process. I think that WHO, PAHO, the United Nations have put it on the table. They say that the only way that we can find health reform in reality is to really consider digital health platforms as a way to really enhance coverage, enhance response capacity, and enhance the way that you are linked with communities and patients. So I think we need a very comprehensive approach around technologies. Telehealth is one aspect, but you have other elements, and it's a very complex, but at the same time, I think very clear path that has been already designed. And as Ana Maria and Liliana mentioned, it's very important to bring it to the real world, and we need to build up that experience in Latin America. There's a very good, I would say, coverage with internet, smartphones. The cost is coming down. Yes, there's already let's say a gap with the rural areas, but today there's technology that can be adapted and it can be embedded in order to use technology in the local sites. And I think we should really address that point as a part of the important, I would say, way to really move into making a universal health coverage process. And going to your original question is, I think that's an element that is part of a policy that has to be considered when you have let's say, you offer the process of universities and technicians. You need to be very clear that at the end of that process, they're going to need a place where to work. So it is, I would say, like an essential question that you're not just going to give opportunity to have health personnel because they want to be within that professional in their lives. There's a lot of frustration due to that. You have a number of general practitioners that don't even work as general practitioners because there's no place where they can work, or if they have to work, they have to really be in second-class settings that they never thought that they were going to be a physician in that way. It's not the case of nurses. I think in nurses, we need to really revalue. And I think we already mentioned, nurses were really, I would value once more time, because I think we have always valued the importance of the nursing practicing nursing. It's really pivotal for any process that you can do within any health system. And we have seen it in vaccination, we have seen it in health promotion, in a number of other areas where nurses have been crucial. And I think we need to really build up that policy. And why is it they move from one country to another? I would say that is very, very economically driven. There's opportunity, there's job opportunities. There's a way to really find a way to make your life as a dream, if you want to see it, but as also an opportunity that it's not easy to find in your own country. So it's really, I would say, a very, and it's been here for decades already, the brain drainage, and it has gone also in terms of researchers that go out to do their training outside their original country, and they never come back because they don't have the settings and the resources to come and do the same thing that have been trained for. So I think it's really a very complex situation, and it really needs to really look at what you're offering, what is going to be their quality of life. Because let's go down to the earth in terms of any person that decides to go into a health professional, a health career, is because they want to practice that. And they have an illusion. And sometimes families really put all their money, all their resources in order for one member of that family to become a nurse, or to become a physician, or to become a dentist, or to become whatever. And if they don't have a job opportunity, they're going to look for it. And I think that's an essential question that has to be on the table.
It's interesting, Roberto, quickly, I mean, it seems to be a paradox here you're describing. We've talked about an undersupply of healthcare professionals. Now you're talking about an oversupply, that there are cases of training of doctors and who don't find positions in the region. How do you explain the disconnect then between the university's efforts to produce more of these medical professionals and the healthcare systems not being able to have the funding or wherewithal to provide them decent employment opportunities?
I really think that this has been more that training a physician has become a business from different universities, mostly private universities, without really looking at the criteria for the quality of their students. And that's where we see an heterogeneity of the quality of those students. And at least here in Mexico, there's a scale of those that really can reach, and I think Brazil and Chile have the same scale, that they go through a test in order to be qualified to do and to go into a residency. And there you can see that many of those students have been really in very low quality schools. So it's really an expansion of medical school as a business without regulation. I think that there's a need for a strong regulation in order for human resources to be trained as a level that a minimum that you expect for anyone to be great. Because you can have somebody that just passed with, let's say, a C plus versus somebody that had an A plus. At the end, they have the same title. So when you're in front of a patient and you're in front of a physician, you don't know if it's the C or it's the A, and I think that's a crucial. So I think that's where councils, the boards of certification of general practitioners need to be very well established in order to make sure that it's not only enough to become and to finish a university. At least I think we need to have a minimum to really have a certification for general practitioners. That's my point.
We just have 5 minutes left, and Liliana and Ana Maria, I want to give both of you an opportunity to share your final thoughts. I'll offer one question, but please tell me what's most important for us to understand, which is building on what Roberto has just talked about with the training, but the mismatch sometimes between our training of medical professionals in Latin America and the actual employment opportunities, and how policymakers very specifically can start addressing that, whether it's simply a question of spending so that we have adequate budgets to hire the nurses that Ana Maria has pointed out that we absolutely need, or whether it's more complex changes we need to make in our public and private health systems. So I thank you again for all your insights so far, and I'd like to extract one more observation from both of you. Liliana, you first.
Thank you. It's a very relevant question. This is not a problem of budget. Qualities from the university, as Roberto mentioned, is an issue. It's a big issue. In Chile, actually, some universities have been closed because of problem of quality. That's the big issue. It's not enough with the money. We have to change the model or how we give the services. The services have to be much more modern, using technology. We talk about telemedicine, telemonitoring, whatever, because it makes things easier. We are a much smaller country than Mexico or Brazil, and we have a national health system that is well structured to give coverage of services. But we need to be innovative. We need to make things much more modern, and we have to prepare the professionals for these new models, much more ambulatory things, less things in the hospitals, and actually using all of these technology resources, we can be much more close to the patient and solve their problems in a better way. That would be an idea to leave Ana Maria sometime. Thank you very much.
Thank you, Liliana. Ana Maria.
Thank you, Liliana. Well, I have to say that there was a diagnosis made a couple of years ago, like 20 years ago, talking about HR planning in Brazil, and we don't really have it. So we have two very different, and I may say parallel worlds, where people are graduated, where people study, and the labor market. So they don't talk to each other. Of course, there are exceptions, but they are really independent or parallel. We don't have anything like numerus clausus for entry level. We might have numerus clausus for specialization, because some specialties want to keep the numbers down in order to be able to be more recognized in whatever ways there are. But then nobody takes into account population needs. So I was saying before, differently from what happens in Chile, from what Liliana said, our figures of general practitioners is really, our figures are down. We don't value that. The population doesn't value the general practitioners. Brazilians love specialists. The other hand is that the ratio between MDs and nurses in Brazil doesn't make much sense, because we have proportionately much more MDs than nursing staff. So again, it's not efficiently designed health service. Then activities that have to be done by such and such professional, people still don't look at it in an integrated way. It's still very fragmented. And then we don't have a board certification. So sometimes people in Brazil say that you have to have a board such as you have in the US, or like in Brazil, we have something like the Bar Association for lawyers. But when you talk about that regarding physicians, you have almost a revolution. I cannot understand very well. Being a physician myself, I say that I understand, but I don't want to share that with many people because, I don't want to badmouth my colleagues.
Liliana, Ana Maria, Roberto, I want to thank you all for this very insightful conversation on a very urgent public policy issue that we're experiencing throughout Latin America. Today's conversation, I should mention, is part of the Wilson Center's Future of Healthcare in Latin America series, where we're examining challenges in the public and private healthcare systems in this region that have come to light and in many cases been worsened by the pandemic, and how those lessons learned can be applied to improve the quality of healthcare moving forward. I want to thank again our generous sponsor, United Health, for its support for this conversation today. I want to thank you for joining us in our audience, for your questions, insights, and for your attention. I hope you'll join us again in the future as we continue to explore the challenges, but also opportunities, particularly from some of the technologies that we've discussed today to improve healthcare in Latin America and to apply the lessons learned when it comes to resilience and adequate staffing, so that future health crises, when they come, and unfortunately they will not create the kinds of challenges that we have experienced over the last year and a half. Again, thank you, Liliana. Thank you, Ana Maria. Thank you, Roberto. It's been a pleasure speaking with you. Let's talk again soon.